Good evening and welcome to our TIF Talk Tuesday. Thank you for joining us this evening. We're very excited to have our special guests, Dr. Bly and Dr. Edison. Before we start, just a reminder, my name is Andrea Millers with Endogastric Solutions. This is a live event, so at any time, if you have any questions, please feel free to type them in the comment section and we will do our best to answer them tonight. In addition to that, if you are tuning in, please make sure you tell us where you're tuning in from, and we'll pick one winner to win a I Love TIF Cup tumbler today. So thank you again for joining us. And before we start, I do want to give a little background on our special guest that we have here today. We have Dr. Ryan Bly. He is a board-certified general surgeon specializing in robotic-assisted and minimally invasive laparoscopic surgery, endoscopy, surgical oncology, endocrine surgery, breast surgery, colorectal surgery, reflux surgery, thoracic surgery, and emergency trauma care. He is a graduate of the Ross University School of Medicine and received his general surgery training at Western Michigan University in Kalamazoo, Michigan. Dr. Bly is part of the Surgical Associates of Neenah and affiliated with Theta Care Regional Medical Centers in Wisconsin. Welcome, Dr. Bly, and thank you for being here tonight.
Thanks for having us.
You're welcome. Our other special guest is Dr. Timothy Edison. He is a gastroenterologist who specializes in the medical management of GI disorders. He is a member of the American Gastroenterology Association and the American College of Gastroenterology. Dr. Edison has been recognized with the prestigious magnet recognition and brings nearly 30 years of expertise to the Surgical Associates of Neenah in Wisconsin. So welcome, Dr. Edison, and thank you for being here.
Well, thanks for having me.
Fantastic. Well, we're going to go ahead and start our program. As you all know, we're here to discuss GERD and treatment options for GERD, and specifically the TIF procedure. So we have a really unique situation here, right? We've got our GI and also our general surgeon, where you guys both partner, and then also you both do the TIF procedure. Am I correct?
Mm-hmm. That's correct.
Fantastic. So let's go ahead and start. I don't know who wants to take this first question, but who wants to explain what GERD is and kind of
Let
what
Tim
are the
jump on that one.
Perfect. What are the common symptoms that patients could potentially feel if they were suffering from GERD?
Well, the most common symptom, Andrea, is heartburn, that burning feeling in the lower sternal area. It can also creep up closer to your throat. There's a lot of other symptoms that GERD can present with, including things like non-cardiac chest pain, chronic bad breath, eroding teeth. A lot of people's dentists will complain that their molars are showing more erosions than normal. And that can be from reflux, chronic sore throat, difficulty swallowing, even worsening asthma, hoarse voice, even sinusitis can all be from reflux esophagitis.
Fantastic. Well, not fantastic. There's always a lot of talk or questions about silent reflux. And you had mentioned that, the heartburn is usually that typical feeling or symptom, if you will. What do you consider as silent reflux? Or maybe you can touch a little bit on LPR as well, because I know there's a lot of questions from patients about that.
Well, LPR, laryngopharyngeal reflux, situation where stomach contents are refluxing up and really up close to the voice box. And I didn't mention that chronic cough is also a very common manifestation of reflux esophagitis, and that's kind of where the LPR comes in. We get a lot of referrals from our ENT colleagues for chronic cough, chronic sore throat, and hoarse voice. And a lot of these folks have never had heartburn a day in their life. And studies have shown that about 1/3 of patients who have significant reflux esophagitis have never had heartburn a day in their life. So you're absolutely right. There are folks who have manifestations of reflux and they think, well, it can't be reflux, I don't have any heartburn. But gosh, pretty significant percentage of people have that what you call silent reflux.
All right, perfect. Thank you. And, what do you, as a GI, what do you normally tell your patients to do to manage, their kind of initial reflux or GERD symptoms that they're having?
Well, certainly the ever popular lifestyle changes. So if the smokers quit smoking, seriously curtail alcohol consumption, try to cut out caffeine, anything carbonated, chocolate, peppermint, greasy fried fatty foods, eating late at night, losing weight.
Right.
Some
All
of
the
those
good stuff.
right, easier than others.
And, can you talk a little bit about what treatment options are available today? Obviously, there's a lot of people that are taking, over the counter PPIs or, Tums or whatnot. Can you talk a little bit about that?
Sure. So first line therapy, of course, is to address the lifestyle issues. Following that, we kind of see who falls out symptom-wise. Does someone have reflux symptoms 2 or more times a week? That is somebody who really ought to be seeing a specialist and having a discussion about doing endoscopy, for assessment, particularly if these symptoms are chronic. Chronic in the GI world typically means more than a month or two. And so endoscopy to assess the amount of damage, look for any precancerous conditions, and then starting on a therapy. And so typically, if someone has what we say uncomplicated reflux, they're not having trouble swallowing, they're not losing weight, they're not showing signs of GI bleeding, we would put them on a proton pump inhibitor, something like omeprazole, Prilosec, Nexium, and you're right, 2 of these things are available over the counter. For people who really have less severe reflux, things like Pepcid, famotidine over the counter, which is a much weaker medication, can also be used. Of course, supplementing with things like Tums, Rolaids, things like that.
Okay.
Now, most people can tolerate a proton pump inhibitor pretty well. Immediate side effects include things like headache, rash, and diarrhea. Long-term side effects, people are going to be on these things for years, even decades. You do have to watch out for chronic kidney disease, which is rare. I've been prescribing these medications since 1989. I have seen a few patients who did get the kidney issue. The other one is a low magnesium. There are some GI infections that can occur more commonly if you're taking a proton pump inhibitor. There was a lot of talk in the past about osteoporosis, and most of the randomized, more scientific studies have shown this not to be the case.
Okay, wonderful. So can you talk about, what is the next step when a patient has been taking, medication for a very long time, they're still suffering, they're having breakthroughs, the Tums isn't working anymore. What's the next step? Do they come see you? Do they come see, Dr. Bly? Do they have to see their their PCP first? What do they need to do first?
So usually, do you want me to take that one, Brian? Okay. So usually, at this point, they're already engaged in seeing a gastroenterologist. And so we've done our endoscopy to assess the situation. We have them on proton pump inhibitors. Most of the time, they're okay with that. A lot of folks do not like taking a medication long term. And I do think it's good, to be very conscious and aware of that. Although the risks of proton pump inhibitors are not very high, they're not zero. And we have to respect that. They are doing research currently to see if proton pump inhibitors are related to dementia, which is scary. There is no scientific solid evidence to date, as far as I know, but I know it is being looked into.
Okay.
And, the kidney issue is real, other things. Yeah, I mean, it's not a bad idea to consider a surgical option.
Sure.
If a proton pump inhibitor makes a person nervous, and in a large percentage of patients, we have a lot of folks that are taking a proton pump inhibitor even twice a day, and they're still having significant breakthrough symptoms of reflux, heartburn, cough, sore throat, things like that. Not to mention regurgitation. that really unpleasant symptom where liquid or even particle contents are flowing up from your stomach and up into your chest and even into your mouth. And it's pretty bad graphic, sorry, but people can
it's pretty gross.
Eat their lunch and then maybe cough during a business lunch and actually will spit up part of their lunch on their plate. And the regurgitation is terrible. We have no medication for regurgitation. We don't have anything that's effective for that. And that's really where we start seeing folks that really would love to have a procedure like TIF to fix the problem. And particularly if they have a hiatal hernia. For the listeners in the Ethernet out there, hiatal hernia, if you don't know, is the situation where the top part of the stomach herniates above the diaphragm, and really results in worsening of the reflux and particularly the regurgitation symptoms.
Right. So we have a couple of comments or questions I'm just going to try and get to before we keep going. So Andrew's saying, when I'm eating, sometimes it feels like my food gets stuck and I get a tightening in my chest. I can tell my esophagus is constricting. Sometimes after I eat, I'm constantly clearing my throat. What are your thoughts on all of this?
If you haven't had an upper scope, you should probably get one.
Roger that.
Perfect. Well, speaking of the getting an upper scope, what are the diagnostic tests, or what does a patient have to go through in order to determine whether they're a candidate for a surgical or something more than just medical therapy or surgical option?
So Tim and I that's where I usually get involved if I'm not involved already. If someone, say Dr. Edison scoped him and he was found to have a 4-centimeter hiatal hernia, we then want to make sure that the esophagus works okay, especially like you just mentioned, if someone's having, this food gets stuck up here. So we do a test called manometry. It's a tiny little catheter that goes down the nose, and they have you drink some liquid, they have you drink some kind of viscous type stuff, and it watches and see, does your esophagus, is it coordinated? Is it haphazard? Does it squish in concert like it's supposed to, or is it just all over the place? And if it works okay to pretty well, we have some options. If it works not so well, we have less options. And if it's really bad, we have very few options.
Okay. Thank you for explaining that. Are there additional tests that they would have to go through aside from those two that you had mentioned?
Dr. Edison likes to do the 24-hour pH. I know. You can explain that one.
Sure. So after the manometry is done that Dr. Bly was discussing, now our specialist nurse who performs the procedure now knows exactly where the borderline is between the esophagus and the stomach. And with that information, they can place a very tiny wire, which feeds through the nose and then around the back of the ear. I know that doesn't sound very nice, but the wire is so fine that it really is quite tolerable. And the wire goes down into the esophagus just above that borderline between the esophagus and stomach. It stays there 24 hours. The patient goes home. They're wearing a Walkman kind of hooked to their belt. Probably nobody in the audience knows what a Walkman is.
You just dated yourself.
Sorry.
I did.
Should have been self-evident. But anyway, so the 24-hour pH, it records the amount of acid reflux and, importantly, non-acid reflux, which occurs over 24 hours. So a person can really be refluxing very little acid, but if mucus and stomach contents and bile are refluxing up, and at the same time this is going on, every time the patient has, say, heartburn, cough, sore throat, regurgitation, they press a different button on the Walkman, which then correlates the symptoms with the amount of reflux, whether it's acid or non-acid. And remember, we don't have a great medical therapy for non-acid reflux at this time.
Right.
So that way we can show, look, your symptoms, whether it be cough, is caused by reflux. Your proton pump inhibitor is not stopping the acid, or your reflux is not acid. It's bile. Therefore, this person we know truly will benefit from a fundoplication.
Perfect. Thank you.
The hiatal hernia.
Yeah, so speaking of the hiatal hernia repair, we get lots of questions from patients wondering, how does a doctor determine how big their hernia is? Do you want to kind of explain how you find out if a patient has a hernia in the first place, or if they don't have one?
More often than not, it was found on endoscopy. You go into the stomach and you flip the camera like a candy cane, look back up where the scope is coming through, and you can actually see, how big that hiatal hernia is. Now, sometimes these are picked up incidentally. They got a CT scan for another reason, and oh, look at that, a quarter of their stomach's in their chest. So then we know they have a hiatal hernia. It's been found on cardiac workups for calcium scoring on CT scans. It's been found all sorts of different ways, but the most common would be endoscopy.
All right, perfect. So can you let's go ahead and talk about the TIF procedure. Between the two of you, I know you both do the TIF procedure. Who wants to take, how does the TIF procedure work?
Well, we can bounce it back and forth.
Perfect.
I'll wave the white flag. You go ahead,
Yeah.
Ryan.
So we start with an upper endoscopy, just like we do in the outpatient setting. It's a general anesthesia, though you're completely asleep. We go into the stomach, we take a look, make sure everything looks okay, and then we put the device over the top of the scope. It's about the diameter of my thumb. We go down, advance the scope out and through, and then utilizing a couple special instruments that are on the end of the device. One of them is a little helix to grab the tissue. And to try and remake that valve that's supposed to separate the stomach and the esophagus. And when we use that special thing and pull it in, there's two little spikes that go through and almost fasten it with these fun little 8-shaped fasteners. So instead of unrolling itself, that valve will stay down. And our goal is to kind of make something that looks like the omega sign, almost like an upside down volcano. So that, again, acid can stay down here, let the food through, but not let all the junk come back up into your esophagus. After we're done, straighten everything out, pull the whole thing out, go back in with a scope, take a look around, take some pictures, wash everything out, and that's pretty much it.
Fantastic. Well, now you're gonna have to explain how the hiatal hernia portion of it happens.
So yeah. So hiatal hernia repair, 35 years ago was pretty much always done open through a big incision on the top part of your belly. Early 90s, everybody went to laparoscopy, straight, long, skinny sticks done through poke holes. That is still very much used today. It's a good surgery. In the last 10 years, robotics has really taken off, and now we can do these through an increasingly, both smaller incisions, but with less incisions. I do them through 4 incisions. I can't get any smaller. That's as little as I can get. But it gives you a better view. It's in 3D. The instruments are a little better. So it's progressed in the last 30, 40 years. The hiatal hernia itself, the hole in the diaphragm, if we kind of turn you sideways, it looks like an ice cream cone, a big old scoop of ice cream on the top, and then it tapers in the back. And we need to close the ice cream cone back down. So now you're just left with the scoop on top. And that's how big it's supposed to be for your esophagus to get through. So we close it up with stitches, make sure it's the right size, not too big, not too tight, otherwise you have trouble swallowing. And then we can perform the TIF portion of the procedure.
Fantastic. I've never heard of the ice cream cone analogy. I like that. Very
That's what
cool.
it looks like. Yeah.
You're gonna have to patent
Or I'm just
that.
hungry. That could be it too.
So can you talk about, the differences, Nissen fundoplication is kind of was the gold standard, or is still the gold standard for fundoplications to some degree. Can you kind of discuss the difference between TIF and Nissen?
Sure. So Nissen, historically speaking, we'd go in, we'd free up the top part of the stomach. We've kind of got, God gave us this extra part of the stomach up here. We always joke that that's where the dessert goes. But you free that part up and you wrap it around the esophagus so it looks like a hot dog. So the esophagus is in the middle and the bun is the part of the stomach wrapping around it. It's still a good surgery. It's a good procedure. However, there are some potential drawbacks with it. There's some people who develop what's called gas bloat, where they can't quite burp. There's some people who develop pretty significant problems swallowing, food getting stuck. Hopefully your manometry will prevent you from doing that. However, I have seen it before. especially back in residency. Not everybody used motility. Now, some people do very, very tight wraps, so it's a really tiny hot dog. Some people do them a little looser, more of a bratwurst kind of a thing. But that's kind of the Nissen. Now, a TIF, instead of being a full 360-degree hot dog bun, is more like an open faced. It's about 270 degrees, and it doesn't constrict it all the way. With a Nissen, you're actually wrapping the stomach from inside the abdomen laparoscopically. With a TIF, we're wrapping it through the stomach itself. So instead of grabbing the outside to wrap the inside, we're grabbing the inside to wrap the inside, because that's where we need the valve to be remade. So there's also other bunch of different kinds of wraps. You can do partial wraps from the inside and all that other stuff. We don't need to dive into all that.
But you must be hungry, Dr. Bly.
Yeah, apparently.
Actually, there is a question from Andrea, same name as mine, but what are the benefits of a C-TIF versus doing a toupee?
Ooh, now we're getting a little technical.
We've got some very advanced.
So a toupee is just like the name sounds, the little kind of hair. It's a posterior 270-degree wrap. It is a good surgery. Still use it on occasion. I guess the benefits directly. For some people, especially if there's any sort of issue with the esophagus per se, you can do a very, very loose toupee if their manometry is really, really borderline or very, very poor. The other thing, and again, the toupee versus TIF, toupee, you're using the outside of the stomach to try and remake the inside of the stomach, versus a TIF, you're directly remaking the valve itself. It sort of accomplishes the same thing, but not really. Like I said, direct remaking of the valve versus kind of a twisting the outside of the stomach to remake the inside. You still have to, not everybody can even, I'd say, handle a toupee per se. There's some people who really just can't get anything other than a hiatal hernia repair. Yeah, I was going to say the big difference is mostly kind of that inside type thing. A toupee is a 270. TIF is essentially a 270. They're both wraps. One's internal, one's external. It's a lot more dissection when you're doing a toupee wrap as opposed to a TIF. When we do a TIF, we don't have to dissect out the whole stomach. We just have to do the hiatal area. So theoretically, less risk of splenic injury and that kind of thing. That risk is still very, very low overall.
Perfect. Thank
I've
you.
certainly referred you patients, Ryan, who had significant motility problems, where their swallowing was just poor, and we knew they would never tolerate a TIF, but they had a hiatal hernia and they had a lot of reflux. And for those folks, Ryan has done a hiatal hernia repair with a toupee, and that really has worked out well.
And it's a very, very loose toupee. Yeah, it's more like a 200, and it's mostly, and I guess Andrea too, for everybody, the part of the toupee or part of that wrap is to keep the stomach below the diaphragm too. And for some people, especially if they have a monstrous hiatal hernia and horrible motility, like Tim said, doing that kind of laparoscopic bolstering of the actual GE junction with the part of the stomach can help prevent them from coming back up and at least give them, a much better quality of life. I'm of the opinion I'd rather have somebody who has to take their PPI but has good reflux control and can eat, as opposed to, hey, I'm off my PPI, but I'm stuck on protein shakes. So sometimes a little less is more. There's a time and a place to be aggressive, but especially in the slightly older, horrible motility, large hiatal hernia people, take the less is more approach, keep the reflux down, and get them back on with their life.
Yeah. Good point. Thank you. So can you talk about, what to expect the day of? There's lots of people ask, what can I expect? Am I there? How long is my hospital stay? If I even have a hospital stay, how quickly will I recover? And then the infamous diet question. What happens after? How long do I have to drink liquids for?
Morning of, when I meet him in pre-op, go over everything that we've talked about in the office, make sure there's no more questions. Good to go. Go back to the OR. We do the hiatal hernia repair first, unless there isn't one, in which case then we just jump straight to the TIF. It takes me about 45 minutes to do a robotic hiatal hernia repair. We close up all the incisions, get the patient repositioned, and then Tim comes in and we do the TIF part together. It's just nice to have two sets of skilled hands because there's, he's got buttons and knobs on the device. I've got buttons and knobs on the scope. It just makes it easier and goes faster. And then after we do that, the person wakes up, goes to PACU. We start them on clear liquids right away, juices, jellos, popsicles, that kind of stuff. Stay on that for about 3 days. Full liquids for another 11 days. Now I cheat a little bit at the end of that. If they're doing fantastically, no dysphagia, and they call saying, for the love of God, if I have to eat one more smoothie, I'm going to, throw something out the window. Okay, now we can start with the cottage cheese, the, very finely ground beef or ground turkey, the really, really soft, squishy stuff, small portions, lots of chewing, and then advance them through the diet. So it's about a month commitment to an altered diet. Most people do it very well. Almost everybody comes in at 2 weeks and is just like, I can't tolerate any more full liquids. But they do okay. And most people actually lose a little bit of weight, I've noticed at the beginning. Some people have used this to jumpstart some weight loss overall. But yeah, it's an unintended nice benefit.
Yeah. So one of the things that we see from the support groups or the Facebook groups are, patients that are struggling with the diet and start eating, right away. And that's one thing that we always say. I feel like I'm back in bariatrics where you're like, you have to slow down and take your time. And when you're eating and you got to work your way into it. Can you talk about the importance of that and the reason why you do that, to heal, both the hiatal hernia and the new valve that they've created, and why it's so important for them to adhere to that type of diet.
Yeah.
If you don't mind.
Anytime we do surgery healing, there's swelling. And it's just like, at the bottom of your stomach or the bottom of your esophagus. If it's supposed to be this big and there's swelling, it's going to be this big. You can't fit a piece of steak or a chunk of bread or pasta through there without it getting stuck. So while the healing and the swelling is going on, got to stay on the liquids, make it easy to go down. You don't want to blow everything apart that we just made. As the swelling goes down and the hole gets bigger, perfect. Now we can do the cottage cheese, the fish, that kind of stuff. And that's the important part. The other thing is the hiatal hernia itself. Like I said, we obliterate the ice cream cone and just leave the ice cream. Can't do heavy lifting. It's just like a belly button hernia or groin hernia. Got to really let that thing heal in. Fixing these once is enjoyable and fun. The repeat fix is not fun and not enjoyable. It's much more difficult. And so we like to fix them once, fix it well, and that's it. And unfortunately, we've seen, and Tim has seen this many times, the recurrence. They can be a bear.
Yeah. So interesting. We got a question from Corey saying, how quickly can I return to vigorous exercise post-TIF?
Like heavy lifting type stuff, it's around 6 weeks. A month might be pushing it a bit.
Yeah. Depends on your definition of vigorous.
Right.
Well, yeah, people, power walk and go for a run after just a couple weeks, and that's okay. Downhill BMX biking, you're going to want to give that a good 6 weeks. Olympic powerlifting, maybe more like 2 months. After that, there's no activity restrictions. You can get back to whatever it is you want to do, but it's a sacrifice of a month and a half or so to get this thing under control. And if we do it right, like I said, then it usually works the first time.
Fantastic. We have another question from Derek. He's saying, what are your thoughts on some patients having problems with esophageal spasms after TIF?
I have seen patients with discomfort that lasted up to 2 months following a TIF. I haven't specifically seen spasms. Have you, Ryan?
Spasm? I don't know if I've seen spasm, especially people with a slightly bigger hiatal hernia, especially one that really goes up higher into the chest. People have, not horrendous pain, but there's some kind of, substernal pain that goes a little higher than you would think because we have to dissect all the way up to get the stomach freed up to get it back into the abdomen where it's supposed to be. Spasm, I don't think I've explicitly seen either. The expected postoperative dysphagia, if you eat the wrong thing, yes. Spasm, no, I don't think I've particularly seen that one yet.
Okay.
And certainly there's bloating postoperatively. I'm amazed. I don't see it anywhere near as much as the old Nissen fundoplication. But there is some. I always, have to warn people that they may be bloating for a number of months, and even mild diarrhea. But knock on wood, those things tend to fade away in fairly short order.
All right. Okay. Another question from Tyler. I practice good dental hygiene, but my dentist says I have erosions. Could this be GERD related?
Short answer, yes.
Okay.
And that was one of the things that I had alluded to earlier, is that we do get a lot of referrals because patients' dentists say your molars are eroding quickly, and we will do that 24-hour pH test I was talking about, that little wire, and sure enough, a lot of those folks will show significant reflux, both acid and non-acid.
Okay.
And another, people don't think about not just the molar erosions, but they suddenly develop sleep apnea and snoring. And their spouse is, smacking them all the time. What the heck is going on? And they go to pulmonology, and oh yeah, look, your reflux or your obstructive sleep apnea is suddenly horrible. Reflux can make the base of your tongue get bigger. When the base of your tongue gets bigger, your obstructive sleep apnea gets worse. And when your sleep apnea gets worse, your reflux gets worse. So it's this wonderful, vicious cycle awesome. That we can break in. So we have a good relationship with our pulmonary doctors too, because, sometimes this sleep apnea thing is not just, up here. It's also right at the base of the tongue.
Yeah. So I get to go tell my husband that he needs to get his GERD checked out.
Yeah. Hey, I know a guy, Dr. Edison.
I know a guy. Okay, we have another question or comment. I was put on a PPI by a nurse practitioner a couple of years ago, got food poisoning after a month of taking it, so I stopped. Symptoms started to worsen. Should I go back to her, or should I just go to a specialist?
I do recommend a specialist at that point, since she's already had the traditional therapeutic run, and time to probably have it looked at. If somebody has recurrent reflux after having been on proton pump inhibitor, it's time for a look with an endoscope by a specialist. You want to survey the damage, check the anatomy, look for hiatal hernia. Also important to take a biopsy to check for a funny little bacteria called H. pylori, which likes to hang out in people's stomachs and cause things like ulcer. Also to look for a thing called Barrett's esophagus. Barrett's esophagus is a condition that affects about 10% of all acid refluxers, where the tissue in the bottom of the food pipe actually changes to sort of a mutant form of tissue, which can be precancerous, and very, very important to keep an eye on that. Almost all esophageal cancer at one time began as reflux esophagitis followed by Barrett's esophagus. So very important to get checked out. And you could go back on the proton pump inhibitor, but absolutely taking a proton pump inhibitor does increase your risk of getting a foodborne illness. Wow. The amount of the increase in risk is very small, but may as well be 100% in her case because she got the foodborne illness.
Yeah. Thank you. Yeah, I appreciate that. And thank you for bringing up the Barrett's and esophageal cancer. April was our last month, esophageal cancer awareness month, and we did a lot of awareness campaigns to try and make sure people were aware of that. So thank you for bringing that up. One other question here, maybe our last. Let's see. Again, the same gal, Andrea, not this Andrea, different Andrea. How long will a TIF usually last, especially if you take precautions and don't overeat, gain weight, etc.? Do most patients go back to a PPI once the durability from a TIF is gone?
So
we have exciting new data regarding this.
Yeah, there's really good data coming out of California, 10-year data, that it is long-lasting, durable. not something that you just use, oh, it's going to last me a year off my reflux. No, no, no. Our goal here is to, nip it in the bud forever. As she pointed out, though, things like weight gain, horrible dietary choices can worsen your reflux and can undo some of what we've done. But no, actually, we did one of these on Monday, and the gentleman that I did it with, he just rescoped one of his patients from 10 years ago with the original device, and it still looked great. So no, there's good data out there that this is not only durable, but potential fix, like long-term fix.
Perfect.
And your 10-year data, 80% were either completely off their proton pump inhibitor or taking only every other day, every third days, which is a big step forward.
Yeah. Do you guys keep your patients on PPIs for a little bit before or right after, if you will, for like a week or so? Or
I do. I don't know if it's voodoo or not, but I just feel like if we're gonna try and heal the area right around the GE junction, we should not expose it to horribly harsh acid. I don't know if I have any science to back that up. It just makes sense in my head. So yes, I keep them on their PPI while we're in that acute healing phase.
Sure.
Yeah.
Okay, thank you. One other question. Is it common for a GI and surgeon to work together doing the procedure? Is there
High
more
five.
patient?
Right back at you.
Are there more patient benefits with that approach?
I would say 100% yes.
100%.
Tim and we've been working together almost 2 years now, a little longer. Yeah, wow, you've been stuck with me for 2 years. I'm sorry. But yeah, so Tim, long term, especially if there's things like Barrett's, surveillance endoscopy, Dr. Edison can ablate this if it were to turn precancerous. Sometimes people have concomitant IBS or Crohn's or ulcerative colitis, and so he would follow them. And then, from a surgical standpoint, it's not that we just see them and, oh, okay, now you're all done. No, we see them in follow up and long term if any other issues go up. So no, it's a good team thing to have, because it's not just a one and done. Sometimes these people get lost. Their primary care assumes that the surgeon's going to do their acid reflux. I assume their primary care is going to do it. People just get lost. So no, especially people with Barrett's, I love having Tim involved, so that we have somebody monitoring the Barrett's. They get scoped appropriately every 3 years, and it's just a very good situation.
It's been wonderful. It was unusual that you've got surgeon and gastroenterologist pretty much in the same office, and so yeah, patients come to see one, but the other one is right around the corner and can pop in, and we have a very collegial discussion. So yeah, this has just been wonderful.
That's fantastic. Well, speaking of same office, can you please, and I know we have it up on the screen, but let everybody know who's watching where you guys are located and how can they reach you?
Sure. So we're in Neenah, which is not too far away from Appleton, about an hour and a half north of Milwaukee. Great area here in the Fox Valley. We're on Doty Island. That's right. We have islands in Wisconsin. It's fancy. And both of us, yeah, the tropics. We have a couple offices around, though, a lot of the surrounding cities. Yeah, we're always there. I mean, usually.
Fantastic. And I know, patients are very particular when they're looking for someone to help with treatment options. And there's a lot of patients that will travel too. So I don't know if you get that a lot, but if they find the right doctor or the right team, if you will, like you guys, you never know. But before we conclude tonight, do you guys have any last minute advice that you would give to these patients that are watching? What should they do, or what do you recommend if they are suffering from GERD?
Any of the reflux symptoms that we spoke of, if they're recurring with any kind of regularity, and if taking Tums once or twice doesn't take care of it, if you're losing weight, showing signs of bleeding, really need to get seen as quickly as possible by a specialist for this.
Fantastic. Thank you, Dr. Edison. Anything from you, Dr. Bly?
Yeah, don't suffer in silence. Talk with your primary care provider, if you have good GI in your area, start there. If you have good surgeons in your area, start there. Just start somewhere, because there's lots of options out there, and if you don't talk to anybody, we can't provide them for you.
Yeah, perfect. Well, we can't thank you enough for joining us this evening. I know the patients that are watching really appreciate it, and we at Endogastric Solutions appreciate it. So thank you for joining us this evening. We hope you guys stay safe out there. And to all of you watching, if you are in the Neenah, Wisconsin area, you can find Dr. Bly or Dr. Edison. But if you're not, we do have gerdhelp.com. You can jump on there, our website, and there is a physician finder. You'll put in your zip code or your state, and you'll be able to find a physician nearest you, TIF trained physician nearest you. So thank you again for your time and joining us this evening. And we will catch you next time, next Tuesday, for our next TIF Talk. Thank you and have a good night.
Thank you, Andrea. Thanks for having us.
Thank you, guys.